Good afternoon, everybody. Welcome to IPC Partners IPC Journal Club. And we are going to be talking all about automated hand hygiene monitoring this afternoon. So we've got Dr. John Otter, who has picked a paper for us, which we will highlight in a minute. The slides disappeared, but that's okay. So yes, John's picked a really topical paper that he will introduce when he starts. As always, the main aim of this journal club is to create lots and lots of discussions. So we have the Q&A function, we have the chat function. Please use that because it would be great just to pose lots of questions to John after his talk. For those of you that haven't been before, those that have, you've seen this slide lots of times, but those that haven't, this is a real great opportunity for us to exercise our critical thinking skills, great opportunity for our own CPD, and hopefully build that confidence. So, for your own independent research and study. And also what we have found is such an enthusiastic bunch of professionals that we can all work with and discuss important topics with. And hopefully we'll have a little bit of fun along the way. Just to let you know that this is recorded and the recording will be made available after the event. So I will now hand over to Dr. John Otter.
Brilliant. Thank you, Jude. Thanks for that introduction. Jude, you look a bit freezing. I can see you've got a massive big coat on there. I hope it's not too cold where you are. Because the contrast here is that it's completely boiling. So I'm sitting in my office in London and the radiators are on full blast. So if it looks like I'm in a nice hot country, which some of you may be in, I'm not. I'm in the middle of London and it's a bit grey. So yeah, I hope it's not too cold. Jude, have you ever looked at automated hand hygiene monitoring systems before?
I haven't actually, no. It's not something I've ever, embarked on myself. I've always been really curious and I've kept my eye on kind of stuff as it's come through, but it's not anything I've ever sort of instigated myself, no. So I'm really interested in this.
Yeah, that is interesting. I wonder how many other people on the call are in the same boat. I don't think many people in this country have looked at them too closely, whereas in other parts of the world, I think especially in the US, they've been adopted much more widely, and I think there's more experience and more acceptance of them as sort of the way to go. So that's part of the reason why I chose this paper for today, because I just think we have a fundamental challenge with hand hygiene auditing. Anybody involved in hand hygiene or auditing will understand the complexity of something that on the face of it is quite a straightforward thing. We just want to get some observations of hand hygiene practice that are in line with audited against best practice for hand hygiene, which we would normally see as the 5 moments for hand hygiene from the WHO. But the reality of hand hygiene observational auditing is that it's really hard to do. We have to find enough observations to give us a meaningful data set, which in some wards is easy. In other wards, in some parts of the day, it can be quite hard even to properly observe hand hygiene. We can't go everywhere in a kind of one-on-one consultation setting. It's very difficult to do a hand hygiene observational audit. And then we run into a whole range of biases linked to hand hygiene observational audit. For example, and this is some of them, observation bias. So that's where this phenomenon where if you are observed doing something, then chances are you'll do it better because you know you're being observed. It's sometimes known as the Hawthorne effect. There's also observer bias where the perceived practice of hand hygiene will differ from one observer to the other, even if we're auditing against the same standard. So you might have heard this idea of hand hygiene moments or opportunities clashing together. Where does one moment end and the next one begin? Then we have the idea of selection bias. So that's which time periods we select, which groups of staff we select, which specialties we select. One thing we do know is that hand hygiene practice in the middle of the night when nobody's looking is certainly much lower than during the day, especially when people know they're being observed. So when we look at observational hand hygiene data that's reported, many of you will have seen 95, 100% hand hygiene audit scores reported in IPC annual reports. And we know that that's quite divorced from real life. The average observational hand hygiene compliance figure, when done properly, is around about 40%. And I think hand hygiene automated monitoring systems offer us the opportunity to slice through those biases and actually give us some really powerful, objective, meaningful data on hand hygiene compliance that tell us it how it really is. And that gives us a perfect baseline for improvement. This study also included the idea of using the data from an automated hand hygiene monitoring system to serve as a basis for improvement. So getting various systems for feedback that we'll look at in a minute when we get into the paper itself, and feeding them back to staff so as to try and find ways to actually improve hand hygiene performance and not just monitor it. So those are the two principal reasons why I thought this paper would be an interesting one for us to look at. So the study itself was a prospective intervention study undertaken in 2021-2022 in a large Danish hospital, a very large hospital. I think it's got something like 2,000 inpatient beds, so it's a big place with all the kind of range of specialties that we'd expect to see in a hospital on that scale anywhere in the world. The intervention was done on 4 inpatient wards, and they chose hematology oncology as the specialty to do it in. I think they chose that for a couple of reasons. One was because the patients there are high risk, have a high risk of poor outcomes due to infection. But also it was a sort of standard inpatient setup rather than trialing in somewhere like an ICU where the delivery care is just different. The units in total had something like 64 inpatient beds, and the study included 187 staff, which was multi-professional. So we had some doctors, some nurses, and some cleaners. The hand hygiene system that was used was called SaniNudge, and this is a system that includes sensors that are on the alcohol dispensers to measure when they're activated, sensor on the bed as a sort of proxy for the patient, and sensors on the staff badge. So if a staff member goes into the zone of a patient, which is measured by the sensor, without having activated a hand hygiene dispenser, it's marked down as a negative hand hygiene opportunity. Equally, if they come out of the zone without doing hand hygiene, it would be marked as a missed opportunity for moment 4. And I think there's something in the algorithm about the duration of time they spend in the patient zone without getting too close to the patient as a proxy for contact with the patient's surroundings. But actually, I'm not sure exactly how moment 5 is inferred, but somehow WHO hand hygiene moment 1 before patient contact, 4 after patient contact, and 5 after touching the patient's surroundings are all inferred by the system. The intervention was one of feedback. So following a pre-intervention period, group feedback was provided to all staff, and this was done through weekly meetings with clinical leaders to look at the data and show the staff what the system was saying around hand hygiene compliance. That was then followed by a period of both group and individual feedback, which was period 3, and then a post-intervention period where no specific interventions were included. And this is what they found. I mean, it's tremendously exciting, really, to think that over a relatively short amount of time and a relatively small number of wards, just 4 wards included, they recorded over 231,000 hand hygiene opportunities. Now try doing that using observational hand hygiene audits. You wouldn't get anywhere close with a full-time member of staff on just those 4 wards. You just wouldn't get that volume of information around hand hygiene. Now, you could argue that the information isn't so meaningful, but in terms of the volume of information this system was generating, it's impressive. I think there's some indications in the data that was provided that suggest to me that the data was meaningful and valid, at least at a high level. So overall compliance with hand hygiene according to the system was around the 30% mark during patient care. And that to me has a ring of truth, because that compares pretty comparably with the data that we'd expect to see with properly conducted observational audits of hand hygiene. Hand hygiene amongst nursing staff was generally higher than hand hygiene amongst doctors. So this is a phenomenon we see pretty much everywhere you look, that nursing staff, generally speaking, have higher levels of compliance with hand hygiene than nursing staff. Curiously, though, hand hygiene compliance was lowest in the patient rooms and highest in the medication rooms. And I'm not sure why that would be. It could be because the number of opportunities for hand hygiene was greater in the patient area, and therefore the possibility of missed opportunities was higher. Whereas in a medication room, I suppose you go in, you do your hand hygiene, you do your medication job, and then you come out. So it's perhaps an easier compliance to meet in the medication room. So in terms of whether or not the intervention around the group or the individual feedback improved hand hygiene compliance, from this study, the answer is no. There were some interesting trends in various staff groups that the paper looked into in quite a lot of detail. But overall, the intervention of either group level feedback or individualized feedback made little impact in terms of hand hygiene compliance, which is a little bit of a disappointment, really. When you're reading a study like this, you want to see that it worked. The fact that it didn't work and it's still published is good, because so often negative findings never get published, but this one was, and the authors should be commended for that. So just to give you a little taste of the data sets and the way that the data looked in the paper itself, you can see this is the wards were split into 2 different departments. You can see the 4 different periods, with the baseline, the intervention 1 period, which was group feedback, the intervention 2, which was individualized feedback. And then you can see the dots for the various groups on the chart there. Now, what you might observe quite strikingly is that the one-time hand hygiene did appear to increase above the baseline was in the follow-up period. And you might be thinking, well, why on earth did that happen? And I was when I read the paper. The answer to that is, if you look at when this was conducted, it was around the peaks of the early parts of COVID. And the authors report that there was a peak in patients hospitalized with COVID around the time that the follow-up period began. So I think this is a phenomenon of improved compliance due to concerns around or management of patients with COVID, which slightly confounded the study on this occasion. So a couple of points for discussion before we get to questions from the audience, which we're looking forward to. So the authors attribute the lack of impact of the intervention to the limited scope of the intervention itself. So their point is, we didn't do anything other than have a weekly meeting and no related education or improvement activities, whereas most of the guidance you see around hand hygiene improvement is arguing for a multimodal intervention. The more improvement bases we can cover, the better it's going to be in terms of outcomes of improvement. Data collection was undertaken during the COVID pandemic, which is amazing. I mean, it's incredible they managed to pull this study off, actually, given the challenges of the pandemic. In a hospital of that scale, they would have had all the issues that people working in acute care and all types of healthcare in this country and elsewhere in the world would have faced. And there was this increase in compliance identified during the follow-up period, which coincided with the increase in COVID prevalence locally. So let's think about some strengths and limitations, because it's always important to do that when we're looking at papers and thinking, well, what are the things that weren't reported that could have been significant? So it was undertaken in a large acute care healthcare system in 4 different wards, and that's a strength and illustrates the feasibility of the system. There was impact in a multi-professional workforce that was investigated, so it was good that they weren't just looking at one professional group, but trying to see whether there was any difference in the way that various professional groups responded. That was slightly hampered by the fact they had a small number of doctors and cleaning staff included. It was predominantly nurses who participated. The system was evaluated in hematology oncology as one specialty, so that's a strength in a sense, in that it gives us some information in a specialized specialty, if you know what I mean. But it does mean the findings may be less relevant in other specialties. It wasn't in a general ward setting. The validity of the compliance measurements was not validated with observational hand hygiene audits. And I think I look at that from 2 different angles, really. On the one hand, that means maybe we trust the compliance figures that are reported by the system a little bit less, because it wasn't as if they lined up observational audits that were following similar trends. But on the other hand, I think I would argue probably more strongly that an automated hand hygiene system is measuring something very different. And as long as we're happy with the fundamental technology involved, it's almost that the automated system becomes the gold standard that is then used to validate the observational hand hygiene audits when they happen. So I don't think if you implement an automated hand hygiene system, you'd never do an observational hand hygiene audit again. That's certainly not where we'd be. But I think it gives us a different option of the way that we can manage it. There were some challenges with the feedback process itself. So some staff were unable to make the group feedback briefings due to differing shift patterns. They just weren't in the hospital. Related to this, the weekly briefings didn't always happen at all due to operational pressures. And again, we're back to the COVID scenario. One of the wards, I think, had actually quite a low compliance with the weekly feedback, and it was bi-weekly at best. In terms of the individualized feedback, it was sent via an email to the staff member, and the figures show that only a proportion of those emails were ever open. So there's a chunk of staff who didn't receive their individual feedback. So the long and short of that is that some staff had more exposure to the group and individual feedback than did others, and that could confound any measurements of impact. So what does this mean for IPC? Well, based on the findings of this study, automated hand hygiene provides a viable alternative to observational audits of hand hygiene. It was able to be implemented successfully in these 4 wards. It generated data that we could see differences in staff groups and had a ring of truth around the compliance figures that were generated. Simple feedback of hand hygiene compliance in this setting by this system alone seemed to make little impact on improving hand hygiene practice. We need to qualify that with the context. This was during the pandemic. There was a lot going on, and perhaps a different intervention using the same data set may have been much more powerful. So should we consider implementing automated hand hygiene monitoring systems? Yes, but we do, I think, need to consider cost and cost effectiveness of these systems before we take the plunge. So Jude, I'm going to stop sharing and open up to any questions that have come in, but do please fire away, because these events
that was really interesting, and you presented that really clearly. It was fab. So yeah, we've had actually, I put in the chat just as you started, John, I asked people if anyone was actually using automated hand hygiene systems, and we had a couple of people come through to say that they were. So we've got Camellia, who says that they're using it in one hematology unit. Doesn't say where they are, but that's okay. And then Lee says that they've tested it in 6 different units in southern Denmark. And did you say that this study was done in Denmark?
Yeah, so the Danes are ahead of us. Well done.
Yeah, absolutely. We've got a couple of comments. I'm going to try and go through. So Sally, hi Sally. She said that it would be interesting to combine this approach with digital hand hygiene scanners. What do you think of that?
Yeah, I don't know whether you've had a play with these, Jude. I think this is a reference to the various types of system that measure and monitor and feedback on hand hygiene technique. So you put your hand in the scanner, and it shows you whether or not you've washed your hands properly, and gives you feedback on the parts of your hands that aren't properly decontaminated, or whether your technique's a bit off. I always find them very stressful to do, because I'm meant to know what I'm doing with hand hygiene, but I always get it wrong. But it's okay, because everyone does, and that's the point, because these systems are meant to get us to a point where we can improve. But I think there is definitely potential for combining those 2 points, because as with observational audit of hand hygiene, we're not really focusing on the technique of hand hygiene. I think if you see a squirt of gel going onto the hands, that's enough to give somebody a tick when it comes to observational hand hygiene. But really, we could be then saying, well, how much did you put on? Did you put on the correct volume? Did you actually cover your whole hand with it, or was it a little waft of gel from a half squirt? And so perhaps by combining this with a training package to get staff to go through that process that I've stressfully gone through before, of saying your hand hygiene technique's a bit rubbish, this is where you need to improve, could actually be quite a powerful combination. So it's a good idea.
Absolutely, fab. We've got quite a lot of stuff coming through the chat, John. Claire says, did the paper mention anything of the cost of the system? That's a really good question.
No, not. I can see anything about cost of these systems. I have been involved in some discussions with automated hand hygiene monitoring systems in the past, and typically they're sort of costed per bed per day. But I couldn't give you even a ballpark cost for what they'd be. So that's one thing that needs to come out in a cost effectiveness analysis.
Yeah, definitely. So Camelia, who actually mentioned that she's been using the automated hand hygiene methods, says that the time frame of 11 months feels a bit short to demonstrate that significant and meaningful change, and then recognises that there wasn't a dedicated person assigned to oversee the project. And then talks a bit about their own experience. They've implemented a system at the end of 2023. It said it took nearly 6 months just to overcome initial resistance and distrust. That's interesting. And mentions that the period was critical to establish trust, break down misconceptions, and there's Big Brother, sort of we're looking at you sort of thing. Yeah, and create effective feedback cycles. So that's really helpful input there. Thank you so much. And she's from Belgium, so yeah, it's happening in Europe. Yeah, fab.
So Jude, if I was to say to you then, just on one of the points in that question is something that comes up quite frequently with these automated systems around trust and Big Brother. If I said to you, we're going to implement a hand hygiene monitoring system on your ward, we are going to know how your hand hygiene compliance is, and we're going to feed that back to you. How would you feel about that? Would you be open to it?
I think I would, and I think it's a bit of your point, John. We're all as IPC practitioners should know how to wash our hands, but actually, when someone sits and watches you do it, you're like, have I done it right? Did I do that 5 times? And did I get the thumb and stuff? So I guess it does create that bit of anxiety. But actually, I think if you're going to do that, I think you really need that narrative about why it's important that we do know the little bits that we get wrong, because it's about ensuring that we don't miss key elements of our hand hygiene technique. So I think it really is sort of how it's sort of described and explained to people on why it's there. And it isn't to say, to shake a naughty stick at you and say that you're doing this wrong. It's saying, well, actually, we know that these are the areas that people really struggle with. What can we do to perhaps make that bit easier for them? So yeah, I think I can see why there would be challenges there. But I think, yeah, just really good communication on the rationale for doing it is important.
That is interesting. I mean, I've heard various different ways of addressing this point of sort of Big Brother and feedback and individual feedback, or the possibility of individual feedback. And it can be done obviously at a group level, which is one of the interventions in this study, or it can be done on a professional group level, where you can sort of break it down into different compliance by different staff groups without mentioning individual people. And you could have an anonymized badge approach as well, where the system knows that somebody didn't wash their hands, but nobody knows that it was John or it was Jude that didn't wash their hands. And that can be several different ways of overcoming this concern around Big Brother watching.
I think as well, John, we've got to think about, so it's been a few years since I've been out doing hand hygiene audits. But when I used to be doing those hand hygiene audits, if there was somebody that I spotted that hadn't done it right, I would go over and talk to them to give that little bit of education. It's in a nice supportive way. But you say, you did miss this part, and we discuss it. So I don't see how that's different to maybe an automated system doing that. You don't have that personal touch, but I think can't find the right word. I guess it's gone. I don't know what word I'm trying to say. But in terms of what we're trying to do is pretty much the same. We're just using, instead of using a person that takes a lot of time, you've got this sort of automated system that will pull it together for you.
An automated email goes out.
Yeah, I can
Yeah,
explain why. I can understand why people wouldn't open that one, if I'm honest.
yeah.
It wouldn't be
If
your top
it,
priority, would it?
I'll just, oh, sorry, deleted that email. Didn't see that one. Um, I thought you were going to say something else there. I thought you were going to say that observational hand hygiene auditing gives you an opportunity to deliver some in-person, real-time education that you lose if you just rely on an automated system, which is why I think it's important that we do have a bit of a hybrid approach and we don't sort of
Yeah.
throw out the idea of observational audit, because the last thing we would want a system like this to be is to say, well, we'll just, if we've got the system in place, we can halve our IPC team and do it all through automated emails. We know that's not going to be so effective.
No.
Um,
Mm,
I wonder whether I can just
absolutely.
pick up another point from Camilla's experience in
Mm,
Belgium, and this idea of the lead-in period. I've had some experience of implementing the same Sally Nudge system when I was at a different London hospital group to the one I'm at. And we did a feasibility evaluation in a range of different settings. So we tried to put it into ED, maternity, and a general surgical ward and a general medical ward, just to try and get a feel for how the system landed in various
mm,
different settings. And some of the operational challenges that have been mentioned by Camilla and others definitely reflected our experience. Initially, there were
okay.
some challenges with the sensors not adhering to the surfaces properly, so we had to kind of work through that. And then we had to have the age-old challenge of how do we keep the sensors in the place that they're supposed to be, because staff don't stay in the same ward, or many of the staff are peripatetic and doing ward rounds across the hospital. Not all staff are attached to one area. So do they kind of drop their badge in a pot on the way out and somebody else picks it up on the way in? How are they decontaminated in
Mm,
between? So all these really practical questions. And the same with beds. Beds move all around the hospital. So if you've got a a dispenser that's tagged up on a ward, or the bed itself has a beacon to designate the patient zone, as is the case with the Sally Nudge system, how are those contained within the ward? And I think what it absolutely needs is buy-in from the senior leaders on the ward
yeah.
environment. Because without that, the sensors go missing and the whole thing falls a bit flat. And I suspect that's one of the reasons why the interventions didn't work so well, because of the pandemic and because of the diversity
Mm,
of challenge during that period. The staff just didn't really have the headspace to see through the feedback.
yeah. Yeah, I can understand that. The chat's gone mad, John, so I'm just going to try and pull out some bits that are a little bit different.
Okay.
Um, So there's one sort of practical question, thanks Stephen, around, these systems, can they be used with any dispensers, or, are they upgradable, sort of that practical side of it. I don't know
Yeah, I mean,
whether that study highlighted any of that.
the study didn't highlight it, but my understanding of this particular system is that it is dispenser agnostic, and they have ways to add it to the variety of dispensers that you see. And I think if somebody's out there is looking at systems, that's definitely a question I'd ask, is to say, yeah, how can this be applied to whatever hand hygiene system we have in at the moment? Because the last thing you want to do is have to change all your dispensers
Yeah.
in order to implement an automated monitoring system. That's not really going to happen. So I think the manufacturers have to find a way to make it product agnostic. The other thing
Yeah.
is, several manufacturers have said to me over the years, we'll just monitor the wall dispensers because they're easy, but the bed end dispensers we won't. And I've said, well, that's sort of the end of this conversation in a nice, polite way,
Yes.
because
Yeah, absolutely.
I
Yeah.
want hand hygiene to be done at the point of care at the end of the bed, not in the corridor on the wall. There's probably an argument for getting rid of all wall-mounted dispensers and just having the bed ends.
Yeah, I'd agree with that one actually, John. Yassine makes a really good comment. She's pro observational audits, saying that, yes, they're labour intensive, but they do inform us of compliance to the 5 moments of hand hygiene, and we can then target our actions for improvement. And I guess that's really key, isn't it? That actually what we are doing is doing action for improvement and improving patient outcomes. So yeah, thank you for that, yes, Yashin. So we've got some more questions about cost effectiveness, and what would be the measures in a cost effective analysis. What do you think about that, John?
That is a really good question. You can help me with it, Jude, because I might need some help with it because it's not obvious. But off the top of my head, I think, when we think about cost effectiveness for something like a hand hygiene intervention that's meant to prevent infection, we'd probably want to say, well, healthcare associated infection, that's the best metric. The problem is that to do a study on a scale where you had enough healthcare associated infection to give you a really meaningful sample size from a statistical point of view, you'd have to wire up the whole hospital for a year. And that's going to be a massively expensive study to do. So whilst I think healthcare associated infection as a metric for value is great, I'm not sure it's probably the right one initially, certainly not for the initial cost effectiveness evaluations. So I think I'd be thinking about looking at, and I know this is quite low on the ambition scale, but just feasibility. I think, can it be put in place, and can it generate data that we think is valid from a surveillance point of view to tell us where we have issues with hand hygiene that we can then begin to improve. So I think that's the first and perhaps most important bit. Labour saving metrics might be important, because whilst I'd hate to see this taking the job of an infection control nurse, that would be a real shame. We could certainly talk about reallocation of labour time to other aspects of our service that are lacking and need more, and perhaps averting investment in other areas. The other area to think about is staff sickness, possibly. Because if staff are doing more hand hygiene, we might expect to see a reduction in staff sickness, and that's something we can monitor fairly easily, and comply and congruence really with observational hand hygiene audits as well as an outcome metric.
Great, some really good suggestions there. Hopefully that's helpful for those that have asked those questions. Sally, actually, you just mentioned about healthcare associated infections. It's interesting. Sally says, it would have been interesting to have that review of that data in the area of the time of that study. Now, that's a really good observation, Sally. Yeah, absolutely.
It would. I think I saw something in the chat that the study period was relatively short, and in one sense it was. 11 months is not massively long in terms of healthcare associated infection, but it's also not months. Well, it is months, but it's not 2 months. So it's a fair chunk of time to look at some outcomes. I think the other confounder for healthcare associated infection, as with other stuff in this study, was COVID. So COVID would have happened, and things would have changed, and patient flows would have changed, staff ratios would have changed. So I think it would be quite difficult to pull healthcare associated infections a metric from this study, but certainly from future studies, it would be well worth looking at.
Yeah, and we've got Stephanie from Oxford is saying, we're for a combined approach, and saying that actually some of that automated feedback would actually support sort of the human approach, give excellent support, she said, to the feedback from observational audits. So like you say, having that combined. And then Sally says, actually, it's really interesting to see how some of this work links in with some of the new hospital programs. So that's something that's happening within the UK, building new hospitals. For those of you that aren't sure what that is, particularly thinking about the sort of reduction in sinks and stuff. So thanks, Sally, for that comment. And then we've just got some comments about other ways that we can give good feedback through different mechanisms. Somebody is saying actually the individual email approach wouldn't resonate with healthcare professionals, and we saw that in the study, didn't we, that people didn't particularly respond to that. And actually, is it worth asking people what their preferences are and how they want that feedback? That's not a bad shout. What else have we got here? Just talking about feedback, John, and the best ways of doing that. And it's about actually make somebody, so I'm just trying to find their names, at least who did some of the work in Denmark. It says, let's make hand hygiene more simple. What are the important moments? And I think you've done a little bit of a look at that, John, in the past.
Yeah, I think it's probably true that the relative risk attached to all 5 of the hand hygiene moments is not the same. So if we were to do a poll of this group, and we would say, right, let's rank the risk attached to missing one of the 5 hand moments in order, we'd probably say, and forgive me because I'm going to get my moments wrong. Okay, so you'll probably say the one that is immediately before a sterile procedure, which I think is moment 3, but I don't know, is the highest risk, and that's the one we want to get right all of the time. And you'd probably say that contact with surfaces in the patient room is the lowest risk. And that, I think I'd probably agree with that in the hierarchy. And you'd probably say before patient contact is more important than after patient contact, but we know that hand hygiene after patient contact is higher than hand hygiene before patient contact, because it's all about the psychological triggers. When we deliver patient care, our hands feel contaminated, whereas before patient care, they feel less contaminated. I suppose the other thing to add into that, though, is that frequency comes into it too. So whilst contact with environmental services may be low risk for each moment, there's many more opportunities, and the frequency of that moment is an awful lot higher. So I think we might need a mathematical modeler to throw all that into the room and to give us some answers. But I think an automated system, one of the fundamental limitations we haven't really touched on is that it isn't a human being. It's not actually observing hand hygiene. It's making some inferences on hand hygiene based on various different algorithms and assumptions. So, for example, the system requires you, as the user or the manufacturer, to say to the system that we're going to say that if a person is within the patient zone for more than, let's say, 20 seconds, then we consider that to be a missed hand hygiene opportunity. Whereas you might pop your head in the room, say hello to the patient, be in the zone, but actually not touch anything. And therefore, you wouldn't say you would need to do hand hygiene. It's only when you're going to deliver patient care in some way or another. So I think there still is a question around how much we trust the algorithms behind these hand hygiene audits. I personally, having looked into various different systems, I'm pretty convinced that they're valid, but they also measure something different. So I don't think let's measure them against observational hand hygiene audits so we can get comfortable with their validity is necessarily the best way to do that. I think the way to get comfortable with them is to understand what the algorithms are doing and what they can do and what they can't do in principle.
Absolutely. So we've had quite a lot of in the chat around actually, so where did you put these? You've touched on it a little bit. So if you were to sort of implement this in your trust, John, where would you want these sort of sensors?
Everywhere? Am I allowed everywhere?
No, that's a cop out.
No, it's not. That's what I want. You asked me where do I want them. I want them everywhere. So in an ideal
What would
world,
be your priority? What would be your priority areas? So bed space is a given, right? But where else would you want them?
yeah. So in this study, in the 4 wards that they evaluated, they put the sensors in the patient rooms, they put them in the medication rooms, and they put them in the staff rooms. I don't think they put them in the utility rooms or the utility areas, which would be a really significant area to have them, given the type of stuff that goes on in there. I could have skipped over that bit in the paper, so apologies if any of the team are listening. Feel free to correct me. But the point is that they put them in several different areas of the ward environment. I think that's smart. But as a priority, I think I'd want to have the immediate bed space monitored. Just reflecting some of the comments in the chat, I think it's really important that every hand hygiene dispenser is wired up. I don't think you can say, well, let's just do the bed end or let's just do the wall-mounted dispensers. We need to give staff every opportunity to be compliant. And if they use a dispenser out the room, go straight into a patient zone. I wouldn't want it to say you haven't washed your hands because you didn't use the dispenser right there. That doesn't make sense. That's not good contamination control. And then in terms of the areas of most risk, I think critical care comes to mind as probably the highest risk part of the hospital in terms of healthcare associated infection risk. So in an ideal world, that's I think where I'd want to get information about hand hygiene most urgently. And then we'd be looking at the higher risk specialties. Hematology oncology is here, transplant, and then perhaps we're moving into more surgical, surgical general ward territory, perhaps admissions areas as well in the ED. I think the ED is a tricky one because it's a busy, chaotic environment. I've spent a bit of time in RED today, and there's a lot going on always. So I think it's quite a tricky environment to think of how an automated hand hygiene system would cope. Cool, that was a very long answer, wasn't it?
It was a very long answer. And actually, Thomas, thank you for your comment. It said actually, if you're going to use automated hand hygiene monitoring, you need it on all dispensers, wall dispensers, point of care dispensers, mobile bottles. So, it's absolutely critical if we're going to capture that 100% of hand disinfections. So thank you for that comment. Fab, John. I think we've explored all the questions in the chat. That's been really fruitful conversations. Thank you so much for those that have engaged. It's been a really great conversation. I will hand back over to yourself, John, just to wrap up, if that's okay.
Okay, yeah, just picking up that one last comment that's just come in response to the ICUs. It's tricky in the ICUs because of the proximity of the staff to the patients regularly. So because the staff are often one-to-one or one-to-two with patients in the ICU, they're pretty much always at the bedside or within the zone. So to try and do a kind of zonal system in that setting is always going to be tricky. So Jude, can I just ask you one question? Because you asked me a really difficult question. So I feel like I'm allowed to ask you one. So you hadn't heard much about hand hygiene systems before this. Now you've heard what you've heard. Would you say, yeah, let's implement this?
You know what? I think there's something about a combination approach. And I think I would be keen to explore it. Yeah, I think so. I think it could offer some benefits to support. Yeah, yeah, I think so.
Okay, great. Well, thank you, Jude. And thanks to everybody who joined today. It's great to see so much information in the chat. It's always more fun when we get lots of questions and lots of discussion and maybe a little bit of controversy to talk about. That always makes it a bit more interesting. So let me just spend the last couple of minutes going through what's coming up. We are nearly at the end of 2024, if you can believe it. So this will be our final journal club of this year. So wishing everybody a good break over Christmas. And those who are working, I hope things are relatively quiet. We've got some exciting journal clubs coming up in the new year, a couple of slightly different ones. So on the 8th of Jan to kick off the new year, we've got Dr. Alexander Sunderman, who's from the US, who's been doing some truly brilliant work around genomics and its application in IPC. And he's going to talk to us about genomic surveillance for infection prevention control. So he'll give us an overview of some of the work that he's been doing and some work that others have been doing around how we can begin to embrace genomic surveillance to support our practice. A little bit later on in January, we've got our joint journal club with the Healthcare Infection Society, which will be chaired by Dr. Shannon Ali. And we're going to be talking about risks associated with water systems. In February, Kerry Holden will be talking to us about addressing health inequalities using IPC. And then in March, Dr. Alex Edwards will be talking about how effective is natural ventilation. So IPC partners sponsor these journal clubs, so thank you to them. You can go to the website to find out the live schedule. We'll be scheduling more journal clubs in the new year. Recordings are available on our YouTube channel. And lastly, finally, thank you very much, and we hope to see you in the new year.